during the past 2 years, there's been a bit of a challenge in terms of the public media noticing something. Patients who've been taken off and are now not wanted as patients, these are just all public media. Some of these are kind of scholarly. A fair number of them describe suicides. Not usually going to the illicit market, just gun to the chest. And in Twitter, you discover a lot of things. And I met this woman, Lalina Peacock. Now, Lalina is a social handle. She is not a trained healthcare provider. As of October, and I've talked to her extensively and received written write-ups from her, which I'm glad to share with anybody. I said, please confirm, there are 40 people where you've tried to talk them out of suicide due to opioid dose reduction in the last 3 months, and to your knowledge, mostly successfully? And this is why Lalina succeeds. Listen to this. To my knowledge, yes, mostly successfully. I try to keep tabs on people as best I can. Hardly scientific, I know. I ordered a new laptop so I can keep better track. And with the consent of the person she was counseling, although they're not identifiable, here's an actual conversation between her and someone. I took my meds yesterday as needed, not as reduced. I was looking back at my post. Jesus. I was ready to end it, Lalina. Even had a plan to go to doctor's office and blow my brains out after giving him a speech. I know you were. I'm so glad you did. That's not a person who's a trained healthcare provider, which is probably more effective than most of us who are trained healthcare providers. So what has alarmed me is this population, which now has a name, paying refugees. Doctors see liability, insurers see liabilities, CVS Express Scripts see liabilities, NCQA has announced that these people are liabilities. So what do you do with liabilities? You contain them and you eject them. So I'm going to close with a little bit of ethics and a policy recommendation. First question is, do we ordinarily take non-consensual actions on patients who are otherwise adherent and stable, absent strong evidence for those actions, that sometimes result in the patient's death? Do we let others induce physicians to take this action? If your answer is no, not usually, then we must ask if we have some justification so powerful as to overcome customary medical ethics. I've been alarmed about this for a couple of years. I made some suggestions to the CDC directly, both in writing and in person, at the Cherish Conference in Philadelphia in June 2017. You can see Dr. Dowell, the first author of the CDC guidelines, sitting next to me, or 2 over from me. I asked if these are controversial. I propose the following non-radical ideas. The CDC should clarify its 7th recommendation. They should assemble stakeholders to gauge implementation of the guideline, as was urged by the CDC's own hand-picked opioid guideline work group in January of 2016. And they should investigate the outbreak of suicides and public suicidal ideation. You may say, what? Do they do that? So, yes, they do that. They have something called the Epidemiologic Intelligence Service. Here, the CDC was brought in to investigate 8 suicides among youth in 2 counties in Delaware. These are not usually widely publicly reported when your teenager commits suicide. They were brought in. It's a serious event. Okay, here's 27 on a public website, all reported in the public media. Here's another one on Twitter. I don't know if it's an overdose or a suicide. I do have permission from the person to show that tweet, but it's a public event. I received a correspondence from a woman who tracks these very closely. She's confident that she has both the name's contact information and suicidal evidence for 54, and she has about 260 leads on people where they often announce the suicide on social media, or the family does, and then no one ever knows who they are, how to reach them. So my suggestions here are that regulators and payers should offer safe harbor for clinicians and patients. That means to pull back from some regulations and metrics and policies that force dose reductions. Why? As I said, it wasn't endorsed by the guideline, the outcomes data aren't good, they don't address most of the overdose risk in the prescription receiving population anyway, and there are these unintended consequences. Final slide. If my talk has raised a concern for you, please ask yourselves the following questions. Might we be harming some very disabled people? How comfortable should we be with policies that leap ahead of the data? If harm is happening, why would a public agency not be willing to investigate despite being asked directly? Remember what I said about the investigation of the suicides. I wrote it, I said, is there something about the lives of people who've received long-term opioids for pain that makes their lives and deaths not worth measuring or investigating when they happen? And that's the heart of my concern here, is who's valued and who's not valued. Again, my views are not those of any agency. The people pictured here may not agree with every single thing I said, but they did consent to be named. And I think we should go to discussion. And I thank our videographer.
Around the suicide. So I really need to question you about this because where are the documented suicides of people who who committed suicide because of opioid taper? You know, I've seen a lot of newspaper articles quoting people saying, "Oh, it's really underreported. Oh, is that why you can't come up with an actual case?" There was a TV program that had the case of one person whose wife actually handed him a gun to kill himself. I've got some issues with that.
I interviewed the wife.
There is a high rate of suicide among long-term opioid users, which you did not mention. And then you've got these, Twitter things of people who are threatening suicide, which is not at all the same thing as committing suicide. Where is your evidence that there actually is, where is your evidence of documented suicides from people who were tapered?
So first of all, I think it's very important to know a couple of things. First of all, it's great to ask for evidence. That's why I really want public health authorities to investigate suicides right off the bat. That's the most important thing, is when you initiate policy that's not supported by evidence, the very least you should do is set up a structure to collect the data concerning the outcomes of what you do. It's bizarre to not collect the data.
What evidence-free policy? You've said yourself that the CDC guidelines do not actually call for a forced taper. Who's calling for a forced taper? No, maybe this is a payer issue.
Well, actually, I tried to describe the CDC's guideline itself really doesn't.
Right.
It really doesn't. So
Right.
the policies
so
that are...
don't blame the CDC.
The only thing I blame them for is not wanting to follow up on the recommendations from their own hand-picked opioid guideline work group. When they appoint a group to give them advice and they don't follow the advice they receive, I do hold them responsible for that. I would be still concerned that they're not defending their own guideline. Those are both simple. However, the policies that I named are actually more complex. They're not set by the CDC. They involve the quality metrics that punish physicians and healthcare providers based on the number of patients at a given dose. They involve payer refusals. They involve regulations and some laws, but often regulations from the medical board that leave physicians with the sense that they are extraordinarily at risk if they're to continue anyone over 90. Because the Department of Justice, among others, has said we're going to use prescription patterns to figure out who to go after. So you're on notice if you're the last one standing with a patient over 90. Those enact and weaponize the guideline that is written seems pretty good to me from the CDC. But unfortunately, the people who are enacting and weaponizing the guideline have not elected to measure outcomes that are 100% available to them. I will say this, I personally have reviewed the medical charts on 2 patients who are in the media. One of them is the person whose wife bought him a gun. I'm glad to have people
Handed it to
the article. And I both reviewed the medical chart in detail, had an expert review it, interviewed the individual, and had signed consent to publish about it in the Health Affairs blog in January. There's a separate case, which I published in Slate last summer. I have personally been the person called upon to remediate individuals who are suicidal or who have actually shot themselves and did not die. And therefore, I feel fairly convinced, having reviewed the charts of those people, that I know what was going on. Moreover, I'm in continuous contact with physicians who are all addiction trained, who have tons of expertise in opioids and dependence. Those physicians who I'm in contact with basically write me notes every week saying it's a disaster zone with the number of patients who are traumatically harmed. I published a case first in The Hill under a changed gender as a female, and then when I got official VA permission, I published that case in the meeting proceedings for the Association for Medical Education Research on Substance Abuse. That case was medical harm, not suicide. But in any case, I think I've made the case that the CDC guideline doesn't say to do something. The evidence doesn't support doing something. This thing is being done. There's no way you can there is a study of involuntary opioid reduction, and the Veterans Administration, according to Lovejoy, 80% or so of opioid discontinuations are initiated by the clinician, not the patient. And that same team published a separate paper profiling the onset of suicidal action, not necessarily resulting in death, or suicidal ideation in about, I'm thinking about 8 to 12%. What you said about pain also being a thing that induces suicidality is true.
Opioid use is associated with suicidality.
You have
can't leave that out.
You have three things that are all potentially simultaneously associated with harm. Pain itself, opioid dependence, the dependence itself, and the event, however we wish to interpret it clinically, as a resurgent pain or untreated opioid dependence in patients who are having opioids taken away. I would point out, you heard from Bruce, if someone is diagnosed with opioid use disorder, there's no one here saying that forced tapers are the way to go.
Right.
For people who have long-term pain who are in high doses of opioids, the form that their dependence takes can be very benign, it can be rather unbenign, and it can qualify as full-fledged addiction. To assert that all those people should also be subject to the very thing that we would never countenance for someone with diagnosed addiction seems to me quite bizarre, when there's only a trial with a 91% failure rate to suggest it might be dangerous. So I take your point that we should document and study, and I'm on two teams trying to document through health systems records events that happen after opioid discontinuation. So I spend hours every week in discussion trying to pull the data together. That's what we should do. But the people who have much larger resources to investigate outbreaks of things of concern could do that, and they're not doing it. And I don't know, can you defend not investigating?
Yeah, because you haven't shown there's an outbreak. Nobody's shown there's an outbreak yet. So that's what, we use government resources to foresee something, after there's actually a signal, and a TV show and a case here and there is not necessarily.
So the note I received was about 54 where the names and identifiers were known. I've personally witnessed, the physicians that I work with have witnessed, and I've personally reviewed cases. And the question I would have for you is, at what point does something go from being, it almost seems like a little bit of a double standard here. It's sort of, it's not an outbreak until you have large databases to show it, but we can't commit the resources to investigate until you have large databases to throw it. It's
not large databases, documented cases. So I'm glad you're writing.
I documented too in the press after records of review.
And that's nothing compared to the number of people on opioids who commit suicide. And one of the things that you left out is opioid-induced depression, which is.
I would say you've misconstrued if you thought I wanted to minimize the harms from opioids. That's a misapprehension of what I was trying to say. There are significant harms that I tried to say up front about the nature of prescribing opioids. If you can avoid them, please do. There are many, many harms associated with them, although there are some people where they naturally are the thing that has to be used. But my goal here really was not to suggest that there was not a massive amount of harm occurring as a result of both prescriptions and illicit opioids ongoing for the last 15 years. If anybody heard that, they missed my message. That was not what I was trying to say. What I am saying is there's a separate population or a related population that is traumatized now. I wouldn't have spent 2 years working on this day and night unless I was quite convinced and had many others who are all addiction trained who are working with me who feel this is a serious issue. Yes?
I think what was most convincing to me was the slide that you had where, 80-something% of overdoses are in people under 90 milliequivalents a day, which I think, if we're going to look at this from a public health point of view, why are we up here talking about this 17% instead of looking at what's going on where we can actually impact it?
Edgewise.
Well, but the thing is, I was going to ask you about this. There are many more people on the lower doses, so the denominator is much larger.
Absolutely.
Exactly.
So the thing is the risk increased for people on higher doses? And
I think it still
I
is,
think it is.
It is.
It is.
but not in the Kaiser data.
Right.
But Kaiser is in the context of what is
Yeah.
essentially a single-payer multi-plan with a lot of multimodal support.
Yes.
Hi, I'm with staff. I just wanted to give you a time check because you're about 5 minutes over, and
And I yammer too much.
So,
Bruce, you should close up and also correct the questions.
Well, I'd just like to throw out one more thing. That I do think buprenorphine, that people on the high doses should be evaluated with the DSM 5 criteria. And
I agree.
I think a lot of them are needed.
Yes.
I'll mention one study of asking pain patients in a primary care practice if they were interested in naloxone. And when they gave the demographics of the population, 20 or 30%, I forget, had experienced overdoses. Now, by the time you have an overdose, you're not just a pain management patient.
You're at imminent risk.
You're
Or harm.
at risk.
Harm.
So I do think buprenorphine, now buprenorphine can be prescribed off-label, but the problem is, in other words, if you meet the criteria of addiction, then insurance would generally, certainly Medicaid, would cover the buprenorphine treatment. But if people don't meet the criteria or are resistant to have their insurance, say that they're being treated for opioid use disorder, then it's being prescribed off-label, and insurance companies won't cover
They
it.
block it, and there's a lot of people who fall in this.
Do you have any experience with that?
I'm in a system where it is possible to prescribe buprenorphine off-label for people who, what I would say, have complex, persistent dependence. The dependence is not just that they're going to have withdrawal for 4 days after they stop the opioids, but they have an emotionally complex dependence that isn't quite addiction. Some of those people, I'm not saying all of them, some of them really are less volatile than buprenorphine. The healthcare system I work in, I'm not here to represent it, but as the Veterans Administration is trying to create pathways to do that. But otherwise, insurers routinely say, you must label your patient with an addiction diagnosis or we will not cover a medicine that is an opioid, but often results in a less volatile situation.
Yeah. So that's just, so thank you, everyone.
I'll stick around.
And we'll certainly be happy to
And by the way,
discuss
thank
with
you
all.
for robustly challenging me. That's very, very important to do. It helps people learn. And whether they agree with me or with you in the end, that's actually not the crucial thing. The thing is that the exchange allows people to really process what's going on.